Tonight's discussant is Dr. Tom Herzog, Deputy Director of the UC Cancer Institute, University of Cincinnati. And we gave this talk right before SGO and got a peek at the early data, and now we have the final data. So I'm looking forward to seeing the talk, Tom. I'll go ahead and turn it over to you.
All right, Charles, thanks so much. I really appreciate it. Can everyone hear me okay? Just nod your head or thumbs up or, yeah, okay, good. All right, wonderful. So it's a pleasure to spend the evening with you, or portion of the evening, hopefully, and give you an update on what's been going on in endometrial cancer, which has been a fair amount. So these are my disclosures that you can see here. And so, in terms of background, I think that really what I wanted to emphasize is what's in the red there. So endometrial cancer is growing at, nearly 2% a year. There's some disparities there. There's a lot to talk about in terms of what's been going on in endometrial cancer. And, there used to be much fewer in the number of cases. When I started doing this, it was like 30,000 cases a year, and we've more than doubled that. So you can see here, this is from 2020, and it's only gone up since then, but we had at that point 65,000 cases a year, causing almost 13,000 deaths, and then we're over 13,000 deaths now. So we're approaching numbers that look more like ovarian cancer in terms of number of deaths. So it points to the number that are at higher stage and more aggressive tumors, and obviously that'll take up a good portion of what we're talking about tonight. We're taking you through the whole recent history of treatment of endometrial cancer. And what I really wanted to focus on is sort of what is the standard that we had, say, 2 months ago, and what is the standard that we have now. And 2 months ago, at the end of that month, was SGO, Society of Gynecologic Oncology, where 2 landmark trials were delivered. And I'll show you that data in a minute. The backbone for that trial came out of GOG 209. So if you direct your attention to the far right of the slide, that was a non-inferiority trial that had gone through iterations going back the last almost 20 years, looking at, can we change the chemo backbone? Can we do drug A versus drug B? What about this combination? What about triplet versus doublet, and so forth? And it took a almost 1,400 patient trial to show that carbopaclitaxel was just as effective, essentially, as adding doxorubicin to that regimen. And so that has, in fact, become the chemo standard of care backbone for the treatment of advanced and recurrent endometrial cancer. And so that saves you about 20 or 30 slides. And I know Charles is happy with that, because we went through the whole history of that before. So I think that is helpful to get us to allow some time to not only go over cases, but also to discuss a little bit about the data that I'm going to show you. Before I do that, though, I do want to give you an update, sort of where things have changed with endometrial cancer. We used to think of type 1, type 2, with the type 1 being the well-differentiated endometrioid cancers, and type 2 being the more aggressive cell types like papillary serous and clear cell. And we've really moved to a molecular model now, where we unfortunately, it's a small percentage, but we have these tumors that have a POL-E mutation, or considered to be ultra-mutated. And they do very well. They do well, obviously, with treatment, and many of them do well without treatment, because the immune system is able to often take these tumors out. So it's very interesting. It lets them develop, but yet is able to, when they try to metastasize in that, effectively remove them or keep them in check. Then you have the microsatellite instability, or hypermutated, the DMMR, if you will. And these represent under 40% of our cancers. And we're obviously going to address that with some of the checkpoint inhibitors and the new therapies that I'll be talking about with the new data. Then we have the copy number low, which is unfortunately sort of this grab bag of PI3 kinase, mTOR inhibitor type pathway, which represents almost half these tumors. And then we have the copy number high, which are P53 mutated. So these tend to be our serous tumors. And they have the worst prognosis of all these patients. So you kind of can get the continuum there in terms of mutational load versus the copy number of alterations that you see, the histology and grade of the tumors, and then the different pathways that are involved. And I think very importantly, looking at, I think the prognosis. And so we have, MSI high or DMMR do really pretty well, especially with the ability now to receive checkpoint inhibitor. POLE, I talked about, do extremely well, and then sort of falls down when you get the copy numbered low, and we still don't do very well with our P53 mutated, functionally mutated tumors. And there's different ways of working this up, and I'm not going to go through all that with you tonight. These are just data off the TCGA data set that looked at, how to sort of work these tumors up in terms of a classification process known as PROMIS. Basically, some of this is actually almost out of date because we do panel testing now where we get all this information all at once. So it's really not this sequential thing that everyone talks about. It's bigger in Europe than it is in the United States these days with all the sequencing that we're able to get instantaneously off of our tumors. But what is important is to understand, again, looking at these Kaplan-Meier curves, you can see the difference between our POLEs and our P53 mutated and then the intermediate. So this is nothing more than visualizing what I just told you in terms of the prognosis of those 4 molecular subtypes. So here's the current treatment landscape of endometrial cancer, fairly complicated. As we've started to break this out into more buckets, it's starting to look a little more like breast cancer than it did endometrial cancer, which used to be pretty straightforward, but not without a lot of effective therapies, frankly, for those patients with recurrent or advanced disease. So we have made some good progress, I think, in the last few years. Because there were phase 2 trials, expansion 1B trials, and so forth that have looked at checkpoint inhibitors and so forth in this space that have shown promising data leading to the phase 3 trials that we have. So the first phase 3 trial I want to address is a trial that looked at, what do we do if you do not have a tumor that is deficient in mismatch repair. And really the biggest advantage was in the proficient group, where we found that adding lenvatinib to pembro did better than physician's choice chemotherapy. And so this represented sort of a breakthrough in terms of treatment for mostly second-line patients in this setting. But you can see the progression-free survival and differences there. And the real difference was in those patients that were PMMR. So it really did change things. Here's the overall survival for those patients and all patients, all subsets, including DMMR. So you can look at that versus chemotherapy. You can see the toxicity, and the combination of lenvatinib or TKI inhibitor with a checkpoint inhibitor, it is not benign in the sense that there's significant hypertension and other side effects that you see. So hypertension, hypothyroidism, colitis is an issue in terms of the timing of that and trying to sort out the relative contribution of which drugs causing that if they're on the lenvatinib pembrolizumab arm. So there's some issues there in terms of using this, in terms of the ease of use. So these are the phase 3 trials that are going to report or have reported in the last 2 months. And some of these are going to report at ASCO, I think, others potentially at ESMO, but we'll probably have most all of these out in the next year. The Ruby trial and NRG GY018 were both trials that have already reported. So we're super excited about that. And I'm going to spend most of the rest of the time here in my little allotted time going over that data, because I think that'll be a fruitful way of getting you interested in understanding where we are today in terms of current landscape. So this is the energy trial. So I don't know if many of you know, I have a GOG background, and I'm the incoming president for GOG Foundation. I'm over the G of energy in that, and also GOG Partners. GOG Partners actually ran the Ruby trial, and NRG, which is part of GOG Foundation, ran the GY018 trial. So I'm very familiar with both of these trials, and very proud of the team that's been able to really change the landscape for endometrial cancer. We had 2 New England Journal of Medicine papers come out on the day that the podium presentations were given, Monday of SGO in March. So again, at the end of March in Tampa. So we were very excited about that. And you can see the design here. So these were advanced endometrial cancer or recurrent endometrial cancer. And if they were recurrent, they had and got chemo, it had to be at least a 12-month gap. So keep that in mind in terms of GY018. Stratified by DMMR, yes or no, and prior chemo, yes or no. And then the experimental arm was carboplatin plus pembrolizumab, and then a maintenance phase. And then the placebo was added for the control arm there, as you can see. So primary endpoint was progression-free survival, and we'll get into some of the differences here. This is the Ruby trial, so looking at a different checkpoint inhibitor. So this is dostarlimab, and this was added to carboplatin in the experimental arm. Again, advanced endometrial cancer, recurrent endometrial cancer. Chemo allowed if completed greater than 12 months ago, and good performance status. Stratified by MSI high versus stable, disease status in terms of the stage, and whether they had prior radiotherapy. Primary endpoint again here was PFS, and there's 2 phases to this trial. So this is Ruby Part 1 that was announced at SGO. And there's a Ruby Part 2 that's looking at maintenance with the checkpoint inhibitor with niraparib as one of the experimental arms for 2 years. And so that data is going to trail this data probably by at least a year in terms of coming out, but we hope to see that data sometime in maybe 2024 or beyond. So we're excited about that as well. Theory behind that is that the PARP inhibitors may increase more neoantigens, thus making the checkpoint inhibitor more effective. That's the thought behind that. So data started leaking out, and it's not very important anymore. I'm not going to take you through it, but just let you know that the data started coming out with dostarlimab and pembro from the 018 and the Ruby trial early this year and late last year, saying that they were very, very excited about the data. With there was not a lot of granularity in the press release, but they felt that these were 2 successful trials, and indeed they were, and I'll show you that data. Now I've been able to, and this is taken from, these are all from Rebecca Aaron, who granted permission for me to show these slides. And I helped her a little bit with the distillation of the 2 talks. But I think what's important is to know that there are similarities and yet differences between these 2 trials. So this is looking at the inclusion criteria. I think one of the things that's important is to understand that Ruby was a little more liberal in that they allowed clear cell and carcinosarcomas and serous tumors in. So they were more liberal with the histology that was included. I've had 2 carcinosarcomas in the last week of the uterus. One just diagnosed on Friday, and I just saw her yesterday. We're going to try to get her dostarlimab because we have that in our back pocket from the Ruby trial, and the insurance should be a little bit easier since those patients were included. And you can see some of the similarities again and differences there.
Tom,
Yeah.
can I just chime in real quick? What are the
Yeah.
viewers just curious why the Pembro was chosen for 5 years?
Going back to this one here.
Yeah.
You could use it up till there, but for most of the patients it was 2 years. That's what they ended up getting. So you could use it that long.
So an admission that nobody really knows how long to give it.
That's true. That's right. So here's the trials again, sort of in schematic side by side to give you a little better idea. Remember that during the chemo and that the checkpoint inhibitor was given every 3 weeks, and then when it went to maintenance, it was given every 6 weeks. So they lengthened it out. And you can see there's different dates here. Charles is going to be perking his ears up with how many months were they on and so forth. So 21 months or 2 years. Sort of became the de facto. I think that was from an early version of the scheme. I'll have to go back and even confirm if anyone was even using that 5 years anymore. Then this is the primary endpoint assessments here. And you can see that PFS by investigator was both of them, but they actually had 2 cohorts essentially with the GY018. Those were 2 separate cohorts, whereas they did a step down in Ruby in terms of the statistical plan. So I'll show you. The assessment cycles were different. So it's a little hard to compare these trials because the assessment cycles were done every 9 weeks initially versus every 6 weeks initially. For GY018 versus Ruby. So a little bit different there in terms of what you see. Stats, again, really 2 separate cohorts. So they split the alpha, if you will, split the baby on 018, and in Ruby, it was a step down. So they just kept sliding the alpha. If they hit their endpoint, they would have passed the alpha down. And you can see how they were able to just keep going on that. So they would just recycle the alpha and look at this. Okay. See if there's anything here. No hypothesis. Yeah. So again, the 018 really 2 cohorts. And then they just had the pre-specified subgroups where they just kept handing the alpha down on Ruby. So a little bit different. Baseline characteristics in terms of DMMR, so about 27-28% in the 018, and a little bit lower in the Ruby trial, about 22-26%, so probably about 24% in that trial, but not a big difference. As you can see here, this is looking at this is our PFS for the DMMR MSI high group for the 2 groups, as you can see. So fairly impressive hazard ratios, very close to one another, 0.3 and 0.28. Highly statistically significant. The medians are not reached in the experimental arms. So very, very impressive in terms of looking at this. The maturity, the Ruby was a little more mature, as you can see. It was 56% mature versus about 38% mature. And the OS is going to be even less mature, as you'll see here. So this is looking at the PFS in the MS stable or the mismatch repair proficient. So you're not seeing quite the same effect here with Ruby 0.76 and 018 0.18. But again, the maturity is 38% there in 018, and in Ruby 65%. But you can see the medians are not as impressive, but not bad, especially in 018, and about 2 months difference in Ruby there. This is the overall population. So this is for Ruby. You can see the PFS there. Hazard ratio is 0.64, and for OS, for the 33% maturity, hazard ratio of 0.64. So this includes in this particular study, about the 25% of DMMR, and then the 75% of MMR proficient. So this is combined. You get a pretty good feel there for what that looks like. So this is looking to again, the summary between these two trials, which I think helps, rather than me flashing through a million slides. I think sort of putting this side by side is helpful. You can see the duration of maintenance was up to 36 months in Ruby, and they did about 2 years of maintenance in 018. So I do think it got amended, because that was the 018 that said 5 years, Charles. So I think that was an amendment that they switched back. What else here? Primary endpoints we talked about. You can see the hazard ratios there, and pre-specified subgroups, looking at the different subgroups there. So fairly impressive data, I think, in terms of where we stand right now. Where do we go from here? Well, I think one of the big places we go is going back and getting those other trials. So one of the things that we'll be looking forward to is the LEAP, for example, where we look to see whether we can actually substitute for chemo with a checkpoint inhibitor. And that'll be interesting to see if we can do that, especially in the DMMR subgroup, but we need to see whether that's actually possible or not. At 10, now we're bringing in a different checkpoint inhibitor with atezolizumab, see how that performs. And then you have the DUO-E, which looks at now also involving a PARP, which, as I said, Ruby will also do in the second part. So when we get Ruby 2, we'll have that data as well. But DUO-E is looking at durvalumab to see if it makes any difference in terms of being able to be potentiated by a PARP inhibitor with olaparib. And so that's the thought behind that process. So I think it's really an amazing time for us as we move to the future, because we have data, and I took all this out, but we have data showing that it's phase 2 data, but nonetheless, the curves are pretty impressive, with anti-HER2 new therapies for those that test positive for HER2. We're seeing the role of ADCs potentially moving into this area as we move forward. CDK4/6s seem to be another area that looks very promising in endometrial cancer, and then really an area that has seemed to gain a lot of momentum just recently is interest in incorporating TROP2 in ADCs as well, as we move forward. So the big thing that we've really seen with endometrial cancer has been this concept of individualizing therapy based on the histology and pathways, recognizing the unique drivers in endometrial cancer and the molecular subgroups, because this has really changed therapy, and our trials now are biomarker driven, and they will be henceforth. And so things have really changed dramatically in the last 5 years in endometrial cancer, and really substantively in the last 2 months. So this is a great time to sit in on an endometrial cancer what's new talk, because things have really changed. So all those are at the FDA right now in terms of the checkpoint inhibitors. We anticipate getting some word this summer. And we'll see what the label shows. But it's going to definitely change the standard of care, and you need to be aware of it, because not only is it in the patients that recur, but it will change frontline advanced disease. So you need to be aware of that, and I think that's really important. So the IOs have significantly transformed endometrial cancer treatment, and we'll continue to see how we move forward when some of those other 3 or 4 trials report that are out there. And then there's some other trials that are just getting going that I think are promising as well. So exciting times, and it's really a pleasure to be able to share this news with you, so that we can talk about it a little bit. So thank you, and let me sort of see where everybody is here. So any questions? First of all, I'm happy to answer any questions, or we can move on to the cases.
I have
I have a quick question. By the way, great talk.
Thank you.
How do you decide between doing dostarlimab versus doing PEM in this setting?
Yeah, it's a great question. I personally don't think there's a big difference. If you can go back and look at the Garnett trial, and you can look at the Keno 158 and all the trials there, you know, there's some subtle differences, but I don't see major differences. As I've used it, I've maybe seen a little less hypothyroidism, but I haven't seen that any data on larger data sets. So I would take that with a big grain of salt. So for me, it's really about how the labels are going to come out, and it's about if they have some of the different cell types that weren't included in GY018. So I mentioned carcinosarcomas, for example, which are not infrequent these days. So those are the types of patients that I would definitely put on dostarlimab. And then, you know, I think there's a great familiarity with Pembro. That's certainly one of the things that may drive treatment. You know, everyone's familiar with it because it's approved in so many different areas. But having said that, I have used dostarlimab both in the trials. We had Ruby open. I was an author on that paper that came out in the New England Journal of Medicine, and we had really good tolerance, and I thought patients did quite well on it. So I think you know, you sort of have to look at the cell type and the label are probably going to be the main things that drive your decision making. And then if there's any personal preferences that come into it, that may change it. But I don't think there's a big difference. They're both PDL, or they're both PD-1s. And I think that they you know, in the rank order of what we've seen in GYN, that they have been the most successful of the checkpoint inhibitors by far. So,
Dr. Herzog, I also had a question. My thoughts with lenvatinib and pembrolizumab, as you may or may not be aware, we use a lot of that in kidney cancer, and part of the LEAP trial. And the 20 milligram starting dose that's recommended is hardly ever tolerated. I'm just curious as to your approach with that with endometrial cancers.
Yes. So it is equally poorly tolerated in endometrial cancer patients who are often heavier, often have comorbid conditions such as cardiac disease, diabetes, and everything else. So what we tend to do with those patients, I should say, is if they're really hardy looking and look like they're in great shape, I will usually start them at 18 because I can use the 10s and the 4 capsules. And if they're not doing well, I can quickly de-escalate by just pulling a 4 off. And so I don't have to rewrite the prescriptions or anything. They're able to use all their meds. So I find that helpful. If they're more frail, I usually start at 14. And there is data showing that there's efficacy at that level. I know some people who start as low as 10 or even lower. I think that's getting a little low when the study, you know, used 20 and then de-escalated from there. So I start at 14 if they're frail, and 18 if they look like they've got a shot at being able to get through it.
Can I ask one quick question?
Yeah.
As we know that, and as think you showed that slide too. Based on molecular testing, there are 4 subgroups like Pol E mutation, MSI high, copy number and low. So we have MSI high is a completely separate group too, based on those molecular testing. How in GY018 we were able to make them as a control arm, not giving them a pembro, even though pembro is approved for MSI high tumors. So giving that group a placebo, can you comment on that?
Yeah. Well, first of all, there wasn't a lot of frontline data. So even though it was approved, almost all the studies had been done in recurrence. So that's sort of how it got through pretty easily. Could you have gotten those patients onto that? Yes, but the degree of the magnitude of effect was not known in that group. So I think that was part of the allure of going on that trial and to conduct
So
that.
just to follow up on the how much chemotherapy adds to the deficient tumor. Say a patient were to get just immunotherapy alone, would they have the same overall survival without chemotherapy?
Well, I think, certainly you've seen that data in colorectal cancer, but we will get some of that data from the LEAP trial, LEAP 001, and there's other trials that people are talking about to try to replace chemo in the DMMR population. I personally think that the chance for technical success on that would be quite high. But we don't know yet at this point. Tim?
Yeah, no, that was my question.
Okay. Thanks. All right. Should we do some cases?
Sure.
Okay, great. All right. So,
This is Dr. Wynn's case, Tim's.
oh yeah, Tim, you want to take us through this?
Sure. I think you just answered that question in your presentation. So it's a 67-year-old.
That's all right. That's a good, means it's a great
postmenopausal.
presentation, maybe. Maybe.
Had abnormal bleeding, passing clot, and went to the ER, had the clot tested, shows carcinoma, had a stage scan, noted only sub-centimeter retroperitoneal and mesenteric lymph nodes, otherwise no gross metastatic disease. Went to have optimal debulking surgery and a sentinel lymph node assessment. Found she has omentum involvement, so technically she's in stage 4B. Molecular test done shows HER2 negative, 1+ MMR proficient, and we sent off a full next-gen sequences pending because she just had her surgery. And the path shows it's a carcinosarcoma, which in at least been known to be poor response to chemotherapy. And even though the Ruby was included in the trial, but not the Pembroke study. And I guess that the questions that you already answers that you should use the dostarlimab since it was included in the trial.
Yeah. That's we did talk about that extensively.
But you consider the Pembro is also equivalent if you were to have the access to Pembro and not the dostarlimab because it's not on a formulary?
Yeah, I if I had a patient, ideally I would use dostarlimab in this setting because of the indication that'll likely come through, which will include that. It'll be interesting to read the label, but I honestly believe that if you couldn't get dostarlimab, yes, I would definitely use Pembro. I wouldn't deny the patient because, as you said, the response to the chemo backbone itself leaves something to be desired. So I think having the IO along with the chemo is well worth doing.
I have a quick question here. If the patient has peripheral neuropathy, you do a platinum on the trial. It's a platinum and a taxane plus PD-1 inhibitor. What do you replace the taxane with?
Yeah, well, they had a no, you couldn't have neuropathy to get on the trial. Now you could, I believe you could substitute within the trial for class of taxane. So paclitaxel to docetaxel with neuropathy, which cuts the incidence. So that's usually the general strategy that one does. Could you use a different chemotherapy agent such as gemcitabine or something like that? But I don't know. It certainly it wasn't within the trial. So, but it within clinical practice that would be a strategy that you could try, but not a lot of data on that. We certainly do that in ovarian cancer, though.
Yeah.
If this patient had a R0 resection, so if that is, I don't know, is there a role for adjuvant therapy in a carcinosarcoma, or you just wait till they relapse?
Yeah, that's a good question. So, so in this case, she had 4B, so that makes it easy, and she had positive nodes. But yeah, if you had a 4B that was even R0 resection, I would still treat her. You may not go as long. You may not do all 6 cycles of the chemo. You may only do, say, 4 and then start maintenance, and you may not do maintenance as long. But her chances of recurrence with a 4B with positive nodes and momentum and everything else is extremely high. So I would not just wait for that to happen. I think your best chance of buying her significant time would be now. Okay. Should we go on to the next case then? Okay.
Dr. Cartwright.
Oh, okay. So yeah, this is my case. Is a kind of a complicated case, but I simplified it. 59-year-old woman who's admitted to the hospital with deep vein thrombophlebitis and pulmonary embolism. She started on heparin but developed HIT. She had severe thrombocytopenia. Her platelets dropped down to 3. I think less than 20% of only 5% of the time with HIT does the platelets drop below 20. But and then she also had a CAT scan of the abdomen and pelvis that showed a uterine mass, ascites, lymphadenopathy. Biopsy was an endometrioid, was ER positive, HER2 negative, proficient MMR. She did have next generation sequencing. We have the results. I didn't put that all in there, but there was nothing else in there. After a long discussion with multiple people involved, I decided to treat her with ergatrovan and Salumedrol, and her platelets rapidly came up. She started on Eliquis, and the Salumedrol was tapered. So she's actually still in the hospital. She got pretty weak. She started on carbotaxol in the hospital. Unfortunately, the patient doesn't have any insurance, so we've filled out patient assistance forms for Pembro, and we haven't heard back yet. So I guess the questions, I never remember, I don't think I've had a patient with HIT or possible ITP or some kind of combination of both. Would that be a checkpoint inhibitor? And do we have to have her completely off the steroids to start the Pembro, or once she's on, say, 20 or less or 10 or less, would it be reasonable to start that?
What's everybody think? This is a relatively data-free zone, so there's no wrong answers here. What's everyone think?
I don't think HIT is completely contraindication to Pembro. With these immuno, we have seen cytopenias, but it's not absolute contraindication to start with.
Yeah, that is true. I looked this up because Charles sent me the cases this morning, so I looked it up this afternoon. You're right. But I didn't see anything on, when you can start, so forth. So I would probably try to get her nearly off the steroids, so like 10 or less. But I don't know what others think.
Well, what about the ITP issue? I think that would be a relative contraindication, right?
Relative, but not an absolute, and that's why I would want to observe her once she's off the steroids to see if that's still an issue. And if it's not, if she maintains her platelet count through the chemo backbone, she's going to have naders, but as long as they're reasonable and consistent with what you would see with carbopaclitaxel, I wouldn't have a problem starting the IO.
Yeah, her platelets have stayed up as we've tapered the steroids, but she was quite sick and in the intensive care unit for like 2 or 3 weeks that we're doing all this. So, and I kind of thought we'd probably wait till she goes home and maybe the second or third cycle after she's off the Pembro. I mean, after she's off the steroids, consider starting the Pembro. But we don't, a hospital doesn't like giving it in the hospital, and sometimes it just takes time to get these things approved. So.
Yep. No, I agree with that plan. As I said, I would see what she does on carbopaclitaxel and off steroids or nearly off steroids. And if she's able to maintain her platelet count, then you're probably okay to try it. But if she has, severe thrombocytopenia just with carbo, might add anything else.
Yeah, I didn't put it on here, but the physicians that seen her in the hospital thought she was so debilitated. She started her on weekly carbotaxol, so she's had it. I think she's had three weeks of it now, and her counts haven't dropped. But it's that with the weekly, it tends to be less myelosuppressive too. So
you see it too.
Yeah.
Right. Okay, great case. Not for you, but thank you. Challenging case for sure. All right.
This is Dr. Zayden, I believe.
Yeah. So this, I'm going to make it quick in the interest of time. This is a 72-year-old patient that unfortunately had a history of bipolar disorder. So all the unfortunate baggage that comes with that from a patient standpoint was diabetic, hypertension, admitted to the ER with a 5-month history of pelvic discomfort and vaginal bleeding with malodorous discharge. Patient had a 25-pound weight loss and developed cough and shortness of breath in the past 2 to 3 months. On direct questioning, she had apparently been to a different ER about 8 months before and said they found something and asked her to follow up with a gynecologist, but she didn't have insurance. We see a recurring theme here. And so she never followed up. When she came into the ER, a pelvic exam showed a purulent bloody discharge. She had a transvaginal ultrasound that showed a significantly thickened endometrium stripe with 20 millimeters, and her CA 125 was over 700. Patient had a CT scan that unfortunately showed multiple bilateral pulmonary lesions with mediastinal and para-aortic lymphadenopathy. We had tried to get a pelvic MRI, but it was aborted since she could not stay still. Gyne was consulted and did a biopsy that showed endometrial carcinoma. She was started empirically in carbotaxol, and after 2 cycles, she refused to continue due to toxicity. So NGS was sent out and showed a TMB of 12 mutations per megabase with microsatellite high. So she was started in pembrolizumab. Unfortunately, after CT after 4 cycles showed decrease in pulmonary nodules. The patient opted to discontinue treatment 2 cycles later since she said she was moving out of state. The reason that we chose that was I think there was data from Keynote 158, if I remember correctly, that showed some benefit to single modality pembrolizumab. And I was just curious as to whether you would have taken a different approach. This was before Keynote 775, so we didn't have the lenvatinib pembro data. At least I didn't. Not that I think she would have tolerated it now.
Yeah, I mean, it doesn't sound like she had the best social circumstances and financial situation, and obviously, and then had a fair amount of comorbidity associated as well, right?
Yes.
So that obviously complicates things. In a perfect world, yeah, at this point, knowing what I know, but we don't have that data, whether you could substitute the carbotaxol with just the IO. But if you were going to do one, I think you chose the right drug with her being MSI high. How the pulmonary nodules have gotten a little bit smaller, or are they getting pretty much?
No, she had a pretty dramatic response. I'd say it decreased by at least 50%, which was more than we use a lot of pembro in other tumor types. It was more than we had anticipated. And her cough went away, her shortness of breath went away.
Yeah.
So-
Unfortunately, it looks like her semi-happy story is not going to turn out so well. It sounds like she just doesn't seem to understand that she needs this treatment, and I guess resources and all that are playing a role. Very
Would you
difficult.
have used dostarlimab if you were seeing this exact case and you could only get away with one type of IO? Is there a personal preference?
No, I think either one for me would be effective in this particular case. I didn't see anything that pointed to just dostarlimab here, so I think either one makes sense. Good data on both, but I hope that she can get on a patient assistance program and get hooked up wherever she's going, because she's probably going to. It's a difference of maybe years for her. It's not like a difference of a few weeks or a month or two. So it's a shame. Okay, and she was. I was thinking of the last one. She wasn't ER positive, Rich. No, I don't think we had ER status on her. All right. Well, Chuck, it's you said you wanted to wrap up around 7:50 or so. We're there. Did you want to do any more, or what do you think we're good for the evening, or?
Well, yeah, I think that's pretty good. Does anybody have any specific questions they'd like to ask at this point?
Hi, Sergeant. A quick question. I just had to kind of target a question. How afraid should I be of a patient with a history of well-controlled MS and using the immunotherapy? I have a patient right now who's a great candidate for immunotherapy, except for her history of MS, which is currently well-controlled. So the question is, how afraid should I be of that?
Yeah, I'd love to hear from others. I'm not. I don't know for sure. Anybody know?
I think that would be a challenge just because of the aggressive nature of MS. I would be afraid, very afraid.
Same here.
Yeah.
Sounds like the fear index is up.
Yeah, that's my thinking.
I guess I guess the question though is how bad is her cancer, and what's going to get her, do you do a trial of it and see how she tolerates it and thing? But how bad's her cancer?
She did great initially. She relapsed, and after having a CR for probably 7-8 months, and she's MSI high, great candidate for immunotherapy if it weren't for the MS. And I historically am very afraid of MS with immunotherapy, so I haven't pushed it. But she's just such a good candidate for it. If it weren't for the MS, I'm tempted to try it, but been too afraid so far.
Yeah. Yeah, I think that's it's a challenge. Let's see here. So there's a paper that came out Neurology, May 3rd, 2022, that looks at immune checkpoint inhibitors in multiple sclerosis. Just need to real quick here. 16 patients, 12 female. Most of them had non-small cell or melanoma. No patients had MS relapses after checkpoint inhibitor treatment, though 2 patients had symptom recrudescence. The 12 patients who had brain MRIs post-checkpoint, no patients had new MS lesions. Checkpoint inhibitor in this cohort was not associated with MSS relapse or new MRI lesions. However, patients in this cohort were older and had benign or inactive MS. Larger studies are needed, blah, blah, blah. So they're covering their butt at the end of that. But at least you got something in the paper that says you could put the two together. So that's all I got for you on that one.
All right, thanks.
Yeah.
Yeah, I think we can go ahead and wrap it up.
Yeah, this is wonderful. Thanks, Chuck, for Charles, for getting us all together and for being able to present this new exciting data in GYN cancers and specifically endometrial cancer. So we'll keep you posted on the labels because that always changes the field as well. And we'll be seeing those labels hopefully very shortly in terms of, what are they going to do with the PMMR versus the DMMR, and are there going to be differences between the labels from those two studies, or are they going to be exactly the same? And I've talked to a bunch of people, and there's varying opinions out there. So we'll wait and see how it comes out. So thank you.
And also, what do we do for second line?
Well, there you have, if they're TMMR, you can certainly go to the lenvatinib plus checkpoint inhibitor. So TKI plus checkpoint. You obviously have a significant number of chemo regimens that you can use. That table I showed you had all the different ones we've gone through over the years, but those are all candidates for what's been used. If you've exhausted carbopaclitaxel, you could go back to that. Hormonal therapies are something to keep in mind. So I do test for ER/PR and have had good responses, including pulmonary nodules. I've had complete resolution of pulmonary nodules on over 5 patients now in my career with complete resolution on those. I often use the Megace, tamoxifen alternating, but then you have letrozole. There's lots of different things you can do in terms of trying to upregulate the receptors to make the blocker more effective. So number of different strategies there. But that's where we are right now. I'm hoping that we're going to have a lot of new stuff coming out with the CDK4/6s, the TROP2s, and all that. And so those trials are all getting underway. So I think you'll see very different approaches to second line in the future. And that's really where the new interest in drug development is right now. What'll be interesting is if it's DMMR and you use just a checkpoint, that'll allow you then to have carbopaclitaxel de novo in that second line. So that'll also be another great option available for us. So good question though. All right, Charles, over to you.
Okay, let's go ahead and wrap it up. Thanks, everybody. Sorry we didn't do all the cases, but I think we tried to select ones that spoke to the various issues and that weren't redundant. With that, everybody have a pleasant night until next time.
Thank you.
Thank you.
Thanks,
Thank
Sean.
you.
Good night.
Thanks.
Bye.